Hi, my name is Dr. Ravi Vij. I'm from MyCancerHaven, and I am here today with Dr. Jeff Cherng, who's Assistant Professor of Medicine at Columbia University in New York. And we are going to talk today about the approach to the frontline treatment of diffuse large B-cell lymphoma, which has been evolving in recent years. And he's an expert in lymphoma, and we're glad to have him on the program today. So welcome, Jeff.
Thanks so much for having me, Ravi. Appreciate the invite.
So we already have done some programs on diffuse large B-cell lymphoma 101, how to work it up. So we're going to dive a little more deeper here into the frontline management specifically. So there are obviously certain things that you probably need to know from a disease perspective before you plan your treatment. So can you talk to us about some of these factors? I understand that one of the things that may be of some relevance is the subtype of diffuse large B-cell lymphoma.
Right, that's exactly correct. So since I think around 2000, we sort of understood that diffuse large B-cell lymphoma is quite a heterogeneous, disease entity and can be divided into two categories by their putative cell of origin subtype. And this really just pertains to what kind of cell the lymphoma is developing from when we look at sort of lymphomagenesis as well as B-cell development in general. And so, DLBCLs can be divided into germinal center B-cell subtype or non-germinal center B-cell subtype, which for the most part pertains to the activated B cells. Okay. And classically, in the past, this was first sort of identified, these differences, using gene expression profiling techniques, which are not available in routine clinical practice. And so we've tried to approximate this with sort of a simplified algorithm called the Hans algorithm, which is sort of a set of immunohistochemical markers that are routinely tested for in the diagnosis of DLBCL. And we look at expression of CD10, BCL6, and MUM1 that helps separate DLBCL into GCB or non-GCB subtypes. And this algorithm sort of misclassifies sort of a small fraction of patients, but in general, sort of a close enough approximation for our purposes. And classically, we've sort of known that patients with GCB DLBCL tend to have slightly better prognosis with standard treatment with R-CHOP. And at least patients with ABC subtype DLBCL tend to fare a little bit worse. This hasn't historically had too many implications with regards to frontline management, but likely has a lot of significance for response to novel therapies. And as we bring more novel agents up into the front line now and in the future, this may play more of a role in our treatment selection for newly diagnosed patients.
So it seems like there were attempts made in the past to treat these patients differently with drugs, but some of these trials unfortunately did not show that treating them in a different manner was going to help the non-GCB subtype, it seems like.
Yeah, that's exactly correct. Ever since R-CHOP became the standard of care for newly diagnosed DLBCL, the field has been trying to iterate on that paradigm by adding additional novel agents, the R-CHOP plus X approach. And a lot of these novel drugs, BTK inhibitors, immunomodulators like lenalidomide, proteasome inhibitors, they all in the relapse setting have at least somewhat shown preferential activity in ABC subtype DLBCL, and this is sort of backed by a fair amount of biologic rationale. So, there have been a number of randomized trials comparing R-CHOP versus R-CHOP plus X, sometimes in just non-GCB DLBCL, sometimes for all comers. And unfortunately, for a myriad of reasons that we probably don't have enough time to get into today, most of these trials have been negative up until most recently, and we'll certainly touch on the successful Polarix study later in this talk.
So what seems to have had some implications in treatment decision making is the gene rearrangements. So can you educate our audience about how this factors in, and then we'll discuss some of the options for treatment?
Yes, certainly. So it should be standard practice for any patient with newly diagnosed DLBCL to have FISH testing or fluorescence in situ hybridization to look for chromosomal rearrangements involving the genes MYC, BCL2, and BCL6. And this is of importance because there's a small subset, 5 to 10%, some estimates, of patients with what we call double hit lymphoma. This has been redefined somewhat recently in sort of the new classification, but classically, what this has meant is a rearrangement in MYC and BCL2 or BCL6. Nowadays, we think it's just more MYC and BCL2 that are important for the definition of double hit lymphoma, but the implication here is that these patients tend to have much more aggressive disease than DLBCL not otherwise specified. They have more advanced stage disease and certainly worse prognosis when it comes to standard treatment with R-CHOP. And so there's certainly a sort of a large body of at least retrospective evidence that suggests that these patients may have better outcomes if they're treated with more aggressive immunochemotherapy regimens. So it's very important in the upfront risk stratification of patients to perform these studies with your HemePath teams.
So there's obviously another term that's often used, double expressors. And so how do they differ? Are they the same as the double hit?
So they're a little bit different, but certainly there's likely a good amount of overlap. Double expressor lymphomas pertain to patients with DLBCL that express MYC and BCL2 by immunohistochemistry. And there are certain cutoffs for what constitutes as positive or negative. 40% MYC and 50% BCL2 is what we use at Columbia, though some centers likely define it slightly differently. And again, historically, we do think that double expressor lymphomas may have slightly worse prognosis than patients who do not have double expressor lymphomas, but we typically don't necessarily recommend any escalation of treatment for double expressor lymphoma alone. Now, certainly double hit lymphomas have a high chance of also being double expressor lymphomas, but not necessarily vice versa.
So just then talking about generally how you approach the treatment of diffuse large B-cell lymphoma, obviously we stage the disease, and without going into detail about how the staging system works, early stage disease, stage 1, 2, is, I think, treated a little differently than people who have stage 3, 4 disease. So could you give us first a little bit of information about how you approach the treatment of patients who are caught at an earlier stage?
Yes, of course. So patients with early stage DLBCL, newly diagnosed DLBCL, do make up a minority fraction of patients, probably a quarter to a third. And it was sort of observed historically that some of these patients with good risk characteristics actually do quite well with a standard duration of 6 cycles of R-CHOP based off of some of the early data. They were seeing sort of progression-free survival rates close to 90% at 6 years out from diagnosis. And so, more recently, we've been trying to look into whether we can safely de-escalate the duration of treatment for some of these patients with early stage disease to maintain their cure fractions, but reduce their exposure to chemotherapy. And so, there are sort of a number of ways that we can sort of approach this, whether it's chemotherapy alone or with combined modality therapy with radiation. I'll sort of address the chemo alone approach here. The 4 cycles of R-CHOP approach was borne out in part based off of the FLIER study, which was a randomized non-inferiority phase 3 study that looked at patients with non-bulky early stage disease that had a low international prognostic index score. So low risk disease, low LDH, age, younger than 60, no more than, one extranodal site of disease. And they randomized patients to either, 4 or 6 cycles of R-CHOP versus 4 cycles of R-CHOP followed by 2 cycles of rituximab alone. And they found that patients with a de-escalated course of treatment had non-inferior outcomes and, as expected, decreased toxicity. And so this is now the standard approach for our low-risk patients with early-stage disease. We don't typically think the last 2 cycles of rituximab alone do that much in an aggressive lymphoma like DLBCL, so we mostly leave that out, though certainly you can, if you want to follow the clinical trial to the letter, you can include the rituximab tail. Now, this approach, at least based off of the clinical trial inclusion criteria, should be reserved, for young patients younger than 60 with no elevated lactate dehydrogenase. But it's unclear whether it's actually safe to sort of expand this approach to the patients that might have one risk factor, patients that are a little bit older. But in general, for the minority of patients that fit that category, 4 cycles of R-CHOP should be sufficient for their treatment.
And then for those that have bulky disease, is that something you treat differently, or is it that's the uniform approach at your center?
We do like to consider sort of, standard duration treatment for patients with bulkier disease. Now, in the FLIER study, it was defined as anything 7.5 centimeters or larger in terms of diameter or largest mass. And bulky has different definitions, sometimes 10 centimeters in other studies, but certainly this, even though it's not classically sort of a risk factor as part of the International Prognostic Index, does give me and others pause in sort of considering a de-escalated approach. And so I think it would certainly be reasonable to treat them with 6 cycles, a full duration of 6 cycles of treatment, because you have more lymphoma to go through and debulk.
So do you see any role for radiation in your early stage disease?
I do, occasionally. There are some older studies that were run through the Southwest Oncology Group, now SWOG, that looked at comparing, chemotherapy alone versus 3 cycles of CHOP or R-CHOP plus involved site radiation therapy. And these patients, that got radiation tend to do quite well. So for patients that either are having major complications of chemotherapy during, the induction phase, or have disease that's quite amenable to safe radiation if it's quite peripheral, say in in the axilla or something like that. So I do like to refer these patients to my radiation oncology colleagues and consider stopping chemotherapy at 3 cycles followed by radiation afterwards. It's always worth a discussion. Obviously, you want to think about the long-term toxicities of radiation, particularly if there, are involved organs in the field, mediastinal disease. You worry about, breast or cardiac toxicities, something in the neck. You worry about the thyroid, stuff of that nature. And so it's definitely still sort of a part of my consideration.
So then, obviously, for the more traditional majority of patients that have stage 3, 4 disease, advanced disease, there's a slightly different approach. So how do you dice that pie?
Yeah, so certainly most patients with advanced stage disease or, stage sort of more worrisome stage 2 disease with a lot of involvement sort of in the abdomen, it's most appropriate to consider full duration therapy, which historically over the last 2 decades and more has been R-CHOP chemotherapy, 6 cycles of immunochemotherapy with rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone delivered once every 21 days. Our EPOC is a more sort of aggressive chemotherapy regimen in a way. It's a regimen that's not delivered just one day in the infusion suite like R-CHOP is, but over 4.5 days, sort of continuous therapy. And it's dose escalated, which means that based off of what happens to the blood counts for the patient with 1 cycle, you can sort of adjust the doses to try to increase it as much as tolerated for subsequent cycles. And as you can see here, also has the addition of the etoposide chemotherapy.
So as far as the outcomes go, is the R-CHOP any different than the R-EPOC for these higher risk patients?
So for most comers, at least in terms of prospective evidence, there has never been a trial that's demonstrated any benefits of dose-adjusted R-EPOC over R-CHOP alone, most notably with the CALGB 50303, I think, study that looked at R-CHOP versus R-EPOC for all comers with newly diagnosed DLBCL, or most. I believe that they didn't include very low risk patients, and they found that there was no difference in outcomes there. Now, there are some quibbles about that study design and whether they enrolled enough sort of high risk patients, but for most patients with DLBCL NOS, including double expressor lymphoma, R-CHOP should be sufficient. Now, going back to what we mentioned earlier, what about the fraction of patients with high-risk cytogenetics, double hit lymphoma, MYC rearrangement and a BCL2 rearrangement? There's quite a large body of retrospective data that suggests that these patients don't do quite as well in terms of progression-free and overall survival with standard R-CHOP alone. And so there's been historically a lot of evidence or a lot of interest in treating these patients with escalated, more aggressive immunochemotherapy regimens, one of which we have a lot of experience now is dose-adjusted R-EPOC. And there seems, to be some reasonable benefits in salvaging these patients' outcomes. You sort of included some data here. There was also a recently published study using the Flatiron database looking at outcomes, and there seems to be potentially some benefits in using R-EPOC for those patients.
So obviously, more recently, there's been this trial that has looked at chemo immunotherapy with Polivy. And obviously, we do have other drugs that are chemoimmunotherapy that are being studied in later lines. But as far as the trial goes, the POLARIX trial, what can you tell us about the trial and how it has impacted your decision making?
Yes, of course. So this is a very exciting, hotly anticipated study that was an international placebo-controlled, double-blind study that enrolled patients with an intermediate or high-risk international prognostic index. So did not enroll patients with an IPI of 0 to 1. And this ultimately randomized patients between classical R-CHOP for 6 cycles, followed by 2 cycles of rituximab alone, versus the replacement of the vincristine, vinca alkaloid, with polatuzumab vedotin, which is an antibody drug conjugate that targets CD79B and has a monomethyl auristatin E payload attached, which we think has a similar sort of toxicity profile as well as mechanism of action as vincristine. So that was why it was sort of replaced in the experimental arm. And the primary endpoint here, which is sort of important for a trial in DLBCL, was progression-free survival.
So, what did we learn from the study?
So this was excitingly a positive study. It met their primary endpoint in looking at a difference in progression-free survival. This was sort of the upfront data that was presented, I believe, at the plenary session at ASH in 2021, demonstrating sort of a modest but statistically significant improvement in 2-year progression-free survival, what looks like 6.5% from pola-R-CHP over R-CHOP alone. Now, at that point, and with slightly longer follow-up, there is still no difference in overall survival between the 2 study arms. So that is important to keep in mind, particularly when we think about sort of salvage therapy, curative salvage therapies for patients, and whether we can rescue these patients. But at least, there does seem to be a significant progression-free survival benefit for the studied patient population.
And did all patients benefit, all subsets?
So this is sort of an area of hot discussion in lymphoma right now. When we sort of dive into the subgroup analysis and look at the forest plots here, there are certainly some subgroups that seem to benefit preferentially from the replacement of vincristine with polatuzumab vedotin. Now, if we sort of go down here, there are some curiosities. Male patients, maybe older than 60, maybe benefited a little bit more. Biologically, it's not clear what exactly that means, and there are certainly hazards in doing multiple subgroup analyses that aren't powered, that you'll sort of tease some things out that aren't sort of clinically or biologically meaningful. Patients with a higher IPI score of 3 to 5 seem to benefit a little bit more, which I think does make sense when you're thinking about, potentially replacing a classical chemotherapy with a novel agent. What's, I think, most interesting is potentially the preferential sort of benefits in patients with activated B-cell DLBCL. We look at the highlighted sort of subgroup analyses here, where there seems to be quite a preference for pola-R-CHP for that subtype, whereas patients with GCB subtypes seem to fall sort of right in the middle, comparing pola-R-CHP versus R-CHOP.
So in your own practice, are you using it in select subgroups? Have you shifted wholeheartedly, or are you not using it at all?
So it's a good question and an area of hot debate, particularly with regards to cell of origin subtype. As I mentioned previously, a lot of the novel agents that we've been trying to move up to the front line in DLBCL may have some preferential activity in ABC subtype DLBCL, and there is some thought that polatuzumab vedotin does fall in that category. CD79B is sort of an important part of the B cell receptor signaling pathway, which ABC subtype DLBCL is more addicted to than GCB subtype. And at least from some of the retrospective studies, there does seem to be a preferential signal for that subtype in those other trials as well. But again, this is sort of an unpowered, unplanned sort of subgroup analysis. So how much can we take away from here? I think we're going to need more real world data to know for sure. At least in my practice, I am definitely giving Pola-R-CHP to any patient with at least non-GCB subtype DLBCL with an IPI of 2 to 5. And I am considering it, for patients maybe with an IPI of 1 as well, not necessarily within the label, but oftentimes we can sort of get it approved. For patients with GCB subtype by cell of origin, I am that do not have double hit or triple hit lymphoma. I am still considering Pola-R-CHP for patients with a higher IPI because I do think it's there may be some preferential activity in higher risk patients there. For a patient with an IPI of 2 and a GCB subtype, I am still considering R-CHOP for some of these patients. But you ask 10 different lymphoma providers right now, and you may get sort of different answers as to how exactly they are deciding between R-CHOP and R-Pola-CHP. It's sort of a problem and a curse as we start to have more and more sort of treatment options in the upfront setting.
So what proportion are GCB and what proportion are non-GCB?
In my practice, probably half of patients are GCB subtype, though I would say a fraction of these are double hit because it does tend to happen a little bit more in the GCB subtype. Maybe a third to 40% are non-GCB, and then there are some patients that are unclassifiable.
So what is the downside? Why not give it to everybody?
Yeah. At least from a top-down view, we do think that the toxicity between R-Pola-CHP and R-CHOP are relatively similar, but there are probably some subtle differences here. Thankfully, the risk of neuropathy versus vincristine and polatuzumab seems to be similar, but there may be sort of higher rates of gastrointestinal toxicity, at least low grade with polatuzumab, higher rates of diarrhea, and certainly there seems to be maybe higher rates of febrile neutropenia with R-Pola-CHP. So, prophylactic growth factor is mandated, at least in our center, for any patient getting polatuzumab as part of frontline therapy, regardless of their age. But you can still probably get away without giving primary prophylaxis to young patients getting R-CHOP. So, there are some subtle differences there, I think, that are worth being aware of. Polatuzumab is obviously a lot more expensive than vincristine as well when we think about cost benefits analysis. But when you're looking at the individual patient in front of you, I'm not sure that should matter quite as much.
So, what is the prognosis of these patients these days? Obviously, the goal of therapy in diffuse large B-cell lymphoma is cure. And with your first-line treatment, how often do you hit that goal?
So I still tell patients sort of across the board, before I even know too much about their individual biologic risk or their stage, that we're probably curing around 2/3 of patients with frontline immunochemotherapy. And I think that still remains the case, really, whether it's R-CHOP or R-Polachip. Are we closer to 70% now? Who knows for sure. So I think that's certainly an impressive benchmark in oncology, and probably partly why it was so hard to iterate on R-CHOP after all this time. I think a lot of our focus right now should be on the highest risk patients, double hit patients with refractory disease during frontline therapy or very high risk IPI. Can we iterate on what we've already achieved to improve those patients' outcomes? Whereas, there's certainly a subset of patients that are going to do well no matter what you give them, with early low risk disease. So are there any tools to continue to de-escalate therapy and reduce exposure to chemotherapy for some of those patients? That's what I'm also interested in.
So what are you most excited about coming down the pike? There are obviously a lot of trials going on to further improve outcomes. What excites you most?
So I'll tell you what excites me and what also makes me anxious. What excites me, I think, is response adapted therapy approaches. What my research interest is in circulating tumor DNA, which is sort of a growing area of interest in aggressive B-cell lymphomas. And so can we couple sort of molecular assessments with circulating tumor DNA sequencing during frontline therapy to help guide any treatment changes, be that escalation of treatments to more aggressive regimens in patients that have suboptimal mid-treatment or even end of treatment, MRD or molecular response, or de-escalate treatment in patients who become MRD negative early on during treatment, so we can sort of decrease their exposure to chemotherapy. Obviously, the implications are sort of quite complicated in terms of these sort of approaches, because historically we've treated all patients exactly the same. Just 6 cycles of chemo, no matter how they're doing, as long as they weren't clearly progressing during treatment. There are a lot of studies now or trials in progress now that are trying to iterate on the success of the Polarix study. Other R-CHOP or now R-Polachip plus X studies adding other novel agents like bispecific antibodies. There's the Zuma 23 study that's looking at upfront CAR T-cell treatment. Can we give very high-risk patients very early CAR T instead of 6 cycles of immunochemotherapy and improve their outcomes? And so, I think time will tell what happens with the landscape in some of these studies, but it just sort of makes future research all the more complicated, because if we have a positive CAR study, what's going to be the appropriate control arm for additional randomized studies in the future? And what are the implications now that we're going to be giving more and more patients CAR T potentially in the future? So I think that's where a lot of sort of excitement is regarding the frontline treatment of DLBCL, at least on the research side.
Well, I really appreciate you taking the time to educate our audience on the recent advances in the treatment of diffuse large B-cell lymphoma, and I hope I can have you back to talk about additional advances as they occur and other topics in lymphoma as well.
Of course. Thank you so much for the invitation again, Ravi, and happy to contribute more.
Thank you very much.